sexual transmitted diseases. We're going to divide this presentation based on the main symptomatology. Let's start with gonorrhea, which main symptomatology is going to be urethritis and cervicitis. Remember, this is a sexual transmitted disease that can affect females and males. If you have a patient, a female patient with gonorrhea, um, male partner should also be infected. So the essentials of the diagnosis for gonorrhea, usually we don't have symptoms, or we can have a vaginal discharge in the case of a female, or urethritis discharge in the case of a male. Females are going to present urinary frequency and also pain during urination, which is dysuria. Diagnosis is usually done by smear exam and a gram coloration. Also, we can do some nucleic acid amplification. If the infection is not treated, it's going to progress into a pelvic infection or septicemia. Main symptoms are going to be painful urination or dysuria, abnormal discharge, sometimes vaginal bleeding. The pathogenesis for gonorrhea, the etiology is going to be caused by a gram-negative Diplococcus bacteria called Neisseria gonorrhea. Remember that Neisseria gonorrhea can infect the urethra, cervix, anal canal, and also the pharynx. It's going to invade the epithelium, and it can cause, if it goes up to the reproductive tract in the female, can cause some pharyngitis. It's a very frequent infection after an exposure with an infected partner. 20 to 50% of men and 60 to 90% of women become infected. Without therapy, females are going to develop pelvic infections disease. The incubation is very short. It is a reportable infection. So, gonorrhea is going to spread through following the tract of the genitals, vagina, uterus, fallopian tube, and then it can spread into the abdominal cavity and from there to the rest of the body. The other main manifestation in external genitalia is going to be the formation of a chancre, and this is mainly caused by syphilis. Here you're seeing in primary syphilis, indicated with the black arrow, what a chancre lesion looks like. Based on essential diagnosis, it's going to be painless. Genital, the chancre, it does not hurt. It's located in the labia, vulva, vagina. It could be located in the cervix, in the anus, maybe in lips and nipples. It does not hurt, but we can have nodes, lymph nodes. It could be generalized, or it could be a regional lymph nodes. And we need to make the diagnosis, of course. 70% of those diagnoses are done by serological test. If we have a secondary syphilis, with time, we're going to see other manifestations apart from lymphadenopathy and a positive serological test. We can see condyloma latum, mucus patches, bilateral symmetric extragenital papulosquamous eruption. In the case of tertiary syphilis, there's going to be implications of other organs like the heart, neurological, ophthalmic, auditory lesions are called gumas. In Latin syphilis, We're going to have a previous evidence um, of an infection, no lesions, and usually tests are going to be there. The titles of serological tests are low, but they're going to be reactive. So the pathogenesis, this is a chronic systemic disease. It's caused by Treponema pallidum. It's transmitted by direct contact of the infection, moist of the lesions, to a sexual transmitted disease, but it can also be transmitted from mother to fetus. In some states of the USA, we have an endemic situation of vertical syphilis transmission. We have syphilis in the United States. The treatment is very, very easy. We shouldn't have vertical transmission. Treponemas can pass through any lesions uh, or even through intact mucous membrane 10 to 90 days later of the primary lesion or chancret. A median level develops around 21 days. Then it disappears, right? And 2 weeks to 6 after the primary lesion appears, the generalized cutaneous eruption. It is characterized by for the secondary syphilis may appear. And after the secondary stage, we have a latent syphilis that can last a lifetime. And then after latent, we can develop a tertiary syphilis if not treated. The later usually can be having manifestations after 4 to 20 years after the disappearance of the primary lesion. Syphilis, it is a reportable disease also. Here you can see the percentage of sensitivity of the serological test if the syphilis is untreated. And as you can see, VDRL usually detects mainly secondary syphilis and latent stage, also primary. There are very low levels for the late stage. FTA ABS, which is a fluorescent treponemal antibody absorbent test, has more sensitivity for secondary latent and late phase, but it can detect also the primary. This is one of the best test diagnosis. And then you have the MHATP, which is microhemagglutination assay for Treponema pallidum, which not so good for the primary stages, but better for secondary latent and late stages. So we do need to combine based on the pathophysiology of the antibodies related to primary, secondary, latent, and late state of syphilis. We do need to ask at least for 2 different tests, including one of these serological tests, specifically those that has to do with fluorescent antibody or microagglutination. Chlamydia, it's another sexual transmitted disease. It produces cervicitis, mucopurulent cervicitis, salpingitis, urethritis. It can progress to pelvic inflammatory disease and can also be transmitted to the neonates during birth of mothers that are infected with chlamydia. Chlamydia trachomatis is one of the most important infectious diseases reported in the United States. Has a very high prevalence in young patients. One of the risk factors is the higher number of sexual partners, and also lower socioeconomic status is associated with high rates of infection of chlamydia. Chlamydia is difficult to diagnose because it's an intracellular organism. It's a gram-negative bacteria, and also sometimes it's difficult to diagnose because if you don't ask the lab specifically, I would like to discard chlamydia infection. They're not going to be applying the specific test to diagnose it. Chlamydia, after chronic infections with chlamydia, patients can develop a chronic inflammatory disease and produce fibrosis. Chlamydia is also a reportable disease. Majority of chlamydia infections in the cervix are going to produce mucopurulent discharge, a lot of inflammatory and edema, ectopias, friability. But remember that usually chlamydia infection, majority are going to be asymptomatic. Herpes simplex is another sexual transmitted disease caused by a virus, mostly by herpes simplex virus type 2, but we're also seeing herpes simplex virus type 1. It is painful. It is characterized by ulcers. It is chronic and also can relapse. It's transmissible even in the absence of lesions. Some antivirus can improve symptoms and speed the healing of the lesions. Pathogenesis basically is genital herpes simplex. The etiology is HSV type 1 and type 2. Most cases are recurrent, caused by HSV type 2. And there seems like a lot of people, 50 million people in the United States, are infected by genital herpes. The infection is increasing in young women and men who have sex with men, but that increasing proportion of herpes infection is attributed to type 1 of HSV. Most patients infected with HSV2 have not been diagnosed with genital herpes. Maybe many of these patients have mild to unrecognized infections, but they can shed virus intermittently in the genital tract. As a result, the majority of herpes infections are transmitted by persons unaware that they have an infection or they are asymptomatic by that moment. The importance about herpes simplex infection during pregnancy is that in a woman who acquires herpes simplex near the time to the delivery, the transmission to the baby is high, 30 to 50%. In women with a history of recurrent herpes at time of term birth or who acquire the herpes simplex virus during the first half of pregnancy, the risk of transmission is low. However, because genital herpes is very common infection during pregnancy, there is a high proportion of neonatal herpes simplex infections acquired from mothers that have a recurrent herpes simplex infection during pregnancy. Okay. Then let's talk a little bit about another type of genital ulcers, but less common. At least granuloma inguinal, less common in the USA. It's called donovanosis. It is painful also. It causes vulvitis, ulcerative vulvitis, and it's chronic and it's recurrent. We do the diagnose with right or Giemsa stain at the lab. It produces granuloma inguinal, as the name says. It's a chronic ulcerative granulomatous disease that develops in the vulva, in the perineum, or the inguinal region, and it's caused by Klebsiella granulomatis, or it has another name, very weird, Calimobacterium granulomatis. It is a reportable disease in the USA. It is very rare. It's more common in Africa. Lymphogranuloma venereum causes painful lymphoadenopathies, um, a genital ulcer also. It sometimes is not evident. Diagnose is done to complement fixation test, and the etiology is caused by some serotypes of Chlamydia trachomatis. They're very aggressive, L1, L2, and L3. If we have the presence of this infection, it's usually associated in patients with HIV that are positive, and this is not frequent in women as it is frequent in men who have sex with men, and usually they are positive for HIV. This lymphogranuloma venereum, it is also a reportable disease. So this is a granuloma inguinal produced by Klebsiella granulomatis, and this is a lymphogranuloma venereum that involves the perineum and also the buttocks, caused by Chlamydia trachomatis. Condylomata acuminata is caused by Haemophilus ducreyi. It's a gram-negative bacteria. It's painful. It also causes ulcer. Then it could cause adenopathy, a suppurative inguinal adenopathy. Condylomato acuminato produces a chancroid. Chancroid, the prevalence has declined in the US, but worldwide it's also declined, but it's still fine in Africa and some Caribbean countries. It is caused by Haemophilus ducreyi. It's an STD infection, usually acquired during intercourse, but also you can acquire lesions in the hand that have been deported, and it's also a reportable disease. With respect to blood-borne infections and also STDs, we have hepatitis B, caused by the virus of hepatitis B or hepatitis B virus. It's acute illness. Usually it's asymptomatic. There is a vaccine available, so nobody should have hepatitis B unless they don't develop antibodies. Hepatitis B can develop a chronic disease, and usually, as you know, it affects the liver. So after an infection, and incubation can be from 6 weeks to 6 months. The concentration of the virus goes high in blood and also can be found in all body fluids, including semen and vaginal secretions and saliva. And that's why hepatitis B can be a sexual transmitted disease. Primary risk factors are associated with infections among adolescents and also among adults that are unprotected during sex, and they have a sexual relation with an infected partners, multiple partners, men having sex with men, a history of having other sexual transmitted disease, and also it has been related with the injection of illegal injected drug use. And hepatitis B is a reportable disease. The other infection is HIV infection, which can, by progression and no treatment, develop into acquired immunodeficient or AIDS. It could be an asymptomatic, it can have an asymptomatic presentation and also immunodeficient syndrome presentation. At the beginning, HIV positive people will have like a flu-like or mononucleosis-like symptoms with weight loss, fever, and night sweats, lymphoadenopathy, pharyngitis, erythematous papular rash, and also lymphoadenopathy extragenital or close to the genitals. Um, in the acquired immunodeficiency syndrome, it's going to be characterized by opportunistic infections, very rare on normal people, like, for example, toxoplasmosis or cryptococcosis or TBC or any other. Also by Kaposi's sarcoma, the counts of CD4 is going to be very low. And in the case of a female, it could be cervical neoplasia. Also, HIV, AIDS can be manifested by depression or any cognitive difficulties. Pathogenesis, this is a single strain RNA retrovirus. This retrovirus uses a receptor over the CD4 cells, and it's the target to get into the CD4 cells, which are mainly going to be depleted in number and in function. They go up to less than 200 cells, and there's when the patient gets opportunistic disease because of the development of AIDS. In the absence of treatment, persons will develop those opportunistic infections and eventually died. So this is a sexual transmission disease, which is greatest for the female sexual partner of a man that has AIDS. Some of the risk factors is the number of exposure to high-risk sexual partners, anal receptive intercourse, presence of infections such as co-infections as syphilis, genital herpes, chancroid, Condylomata acuminata. The presence of genital ulcerative disease also will increase. The infection this is due to a high concentration of viruses in the semen, and during the coitus intercourse cause more breaks into the intraoral mucosa, and these breaks in the mucosa that occur in the anal receptor intercourse increases the chances of acquiring HIV through sexual contact, and the same thing occurs with the vaginal intercourse. More than 80% of females with AIDS occur in women in reproductive age, and this is a very important thing, making heterosexual and perinatal transmission important concerns. In the United States, most of the cases of HIV are subtype 1, even though we do have HIV subtype 2, but they're very low. HIV subtype 2 is endemic in Africa and also in other Europe countries like Portugal and France. AIDS, it's also a reportable disease. There is a campaign in UK which the title is Freeing Babies from Being Born with HIV. We can do also a difference here in the USA because we know there is a vertical transmission of HIV that occurs through the placenta, and that can occur before birth, after birth, during delivery, and postpartum through breastfeeding. We need to educate our patients about the way HIV can be transmitted. We can also offer HIV testing and early diagnosis and treatment for mothers that are positive and that are pregnant to prevent HIV in babies. 30% of women with HIV will transmit the infection during pregnancy and delivery, and 50 to 20% will transmit the infection after breast milk feeding for a period up to 2 years. So we can prevent prepartum and postpartum HIV transmission. Remember that usually mostly the vertical transmission is during intrapartum, but also it can occur in the antepartum period, especially if the woman has not been treated. This is an oral candidiasis in a newborn patient with HIV, which vertical transmission was not prevented. Okay, the mode of delivery of the baby can also play a role in increasing the risk factor for developing pediatric AIDS. Um, during obstetric care, the woman can receive HAART at term if they have rupture of membranes, and prenatal care for a patient that's HIV and it's pregnant has to be individualized. Remember that we talked about other STDs, infections, bacterial vaginosis, and trichomoniasis in previous classes.